Welcome, everybody. My name is Patriquin. I'm a hematologist in Toronto with a particular interest in complement-mediated diseases and in particular PNH, or Paroxysmal Nocturnal Haemoglobinuria. And we're going to be talking tonight about how to identify patients, particularly with those presenting with thrombosis, but also other manifestations that are reflected in this catch mnemonic, which we will go over through the evening. I'm pleased to be joined by Dr. Monika Oliver from the University of Alberta in Edmonton, and we will be splitting this evening's session. Before going forward, my disclosures are listed here, many of them directly relevant to work in the complement space and novel therapeutic clinical trials. It's been a pleasure to be chair of this steering committee for this program. Again, my name is Patriquin, if we've not met, and Dr. Monika Oliver has joined as well. Our colleagues, Caroline Elbaz and Danielle Marceau, have joined and will actually be leading the French program on Thursday. So if you're bilingual, by all means, join both. I think it'll be a great program. Just to point out that this is supported by an unrestricted educational grant from Alexion AstraZeneca Rare Disease. The speakers will be receiving honoraria via Thrombosis Canada, and of course, in terms of other potential in conflicts, Alexion, of course, could benefit from the sale of products that may be discussed in this evening's program. To mitigate this bias, the content of the program was entirely put together by the faculty mentioned earlier and reviewed by colleagues at Thrombosis Canada. So for tonight, or this afternoon, depending on where you are, we hope that at the end of the session, you'll be comfortable discussing PNH, its signs, symptoms, and typical manifestations, and applying the catch criteria, which we will, again, go into in more detail throughout the talk. We want to reinforce the importance of when to test specifically in patients presenting with thrombotic manifestations, and we will describe treatment of PNH and specifically PNH-associated thrombosis. First, a polling question, hopefully not too challenging a one. How do you diagnose PNH in any of your patients? A, yes, or B, no? So we have 23% saying yes, 77% saying no. Okay, polling question number 2. How comfortable are you in managing patients with PNH? A, depends on the patient. B, prefer to refer. Or C, you're comfortable managing on your own. Okay, so we have most people preferring to refer. 18% say depends on the patient, fair enough, and 3% comfortable managing on their own. Okay. All right, so we've got a task. So I'm going to start the evening just going over PNH in general. I'll then pass on to Dr. Oliver going over PNH and thrombosis, how to detect and diagnose, and standard of care for treatment. So PNH, apologies for that, advanced on its own. So PNH is an acquired ultra-rare abnormality of hematopoietic stem cells. It's a non-malignant condition with an incidence we think of around 1 per million annually, and about 10 to 15% of people live with this per million in the population. The name, like many in medicine, is not perfect. However, it's due to hemolysis, or the end effect of hemoglobinuria, being recognized intermittently or paroxysmally, often greater frequency during the night or upon first waking. We can diagnose patients anywhere from pediatrics up to the elderly, but most commonly patients will be diagnosed in their 3rd decade. And based on available data, we don't think there's any clear evidence of predilections in terms of geography, race, ethnicity, or sex. As mentioned, PNH is a clonal abnormality, and the gene that's mutated is the PIGA gene, which is required for the first step in forming GPI anchor proteins. And these proteins essentially serve as chaperones or scaffolding on the surface of our host cells, and effector molecules can bind to them and affect their usual functions. In the context of PNH, we're talking about two complement regulatory molecules, CD55, or decay accelerating factor, and CD59, also known as membrane inhibitor of reactive lysis. And the absence of these is what causes PNH and the natural history. It leads to uncontrolled, unregulated terminal complement activation. And this can certainly arise de novo and spontaneously without any other associated condition, but it's not uncommon to see PNH manifest in patients with a diagnosis of aplastic anemia, but also myelodysplastic syndrome, typically more the hypoplastic variants or other myeloid neoplasms. And if you direct your attention to the right, this figure shows you essentially a normal situation where you can have the classical lectin and alternative pathways of complement all activated. They converge on C3, and C3 is typically cleaved to C3a and C3b, which has multiple roles. It can bind to the surface of a cell and target it for destruction with the reticuloendothelial system or opsonization. You may be familiar with that. It can drive its own amplification loop to make more of itself, and in local relationship to its own convertases, it can bind to it and then lead to formation of what's called the C5 convertase. But what you can see here in this normal situation is there is CD55 bound to a GPI anchor protein. And this inhibits essentially the activity of forward progression of the C3 convertase and proximal complement function. There can be situations, of course, such as a significant inflammatory insult where terminal complement can be activated. This is essentially starting at C5, which is cleaved to C5a, which is a very prothrombotic molecule, and C5b, which can bind to the cell, link with 6, 7, and 8 to be stabilized, and then multiple proteins C9 bind to that and form what's called a membrane attack complex. But again, here you can see CD59 is there as really the sole regulator of terminal complement on the cell, protecting our host tissue. In the context of PNH, you can see these anchors are absent, and for that reason, proximal complement can bind, but it's really the deposition of these membrane attack complexes leading to intravascular hemolysis that leads to the natural history and many downstream complications and manifestations. As mentioned, this is again a clonal process, and this cartoon just shows you what we think is happening, although the exact mechanisms are still needing to be elucidated. But this red cell shows you a stem cell with a PNH clone, or that PIG-A mutation, surrounded really by a normal bone marrow niche. If you move to the right, you can see that there has been some disproportionate damage of the typical stem cells, and this leads to, for various reasons, expansion of the PNH clone and formation of these progeny downstream, showing or manifesting the PNH phenotype in red cells, granulocytes, monocytes, and platelets, and to a lesser extent, lymphocytes. This figure, much more complicated than I would ever be able to design, just shows you the, again, the protective features of CD55 and 59 for our cells. In terms of red cells, that prevents intravascular hemolysis. And for our white cells and platelets, this prevents the increased thrombophilic risk that we will go over later in PNH. But what you can see in the central red cell, absent of these GPI anchor proteins, this leads to uncontrolled intravascular hemolysis and release of free hemoglobin, scavenging of nitric oxide, and many downstream effects that can have a direct impact on overall survival, namely thrombosis, and anywhere between 40 and 67% of deaths are due to thrombosis in untreated patients, but they can also die from progressive pulmonary hypertension, and almost up to 20% may die from progressive renal failure. But if you look at the homunculus to the left, you can also see that there are other conditions and manifestations that may not have a direct impact on overall survival, but can impact morbidity, certainly, and reduce a patient's quality of life. So there are two patients that we'd like to follow through the presentation. These have been fictionalized for privacy, though both patients have given their consent. The medical components have retained. So first is Anna. This is a 33-year-old female who presents to her emergency department with 4 to 5 weeks of intermittent but severe abdominal pain. This has been getting more severe over time. She has some nausea and vomiting. Past medical history really includes miscarriages twice without clear explanation. She has a traumatic brain injuries and seizures following a motor vehicle collision when she was a teenager, and persistent iron deficiency anemia. In the eMERGE, she has investigations including an abdominal X-ray that shows fecal loading, a pelvic ultrasound, which is unremarkable. Her beta is negative, creatinine and liver enzymes really normal. Her CBC with differential does show you a microcytic anemia with a ferritin quite low at 10. Her platelets are also a bit reduced at 130, and she has a normal differential. She started on oral iron and laxative and sent home. Therese is a 35-year-old female who presents also to the emergency department, also with abdominal pain, this time for about 3 months. It's intermittent, associated with nausea and vomiting, but no hematemesis. She comes back now with much more intractable abdominal pain, which is different from her baseline IBS pain, which she has had for years. She is also a smoker, but otherwise no significant medical history. Imaging this time in the eMERGE shows a Budd-Chiari syndrome with bilateral hepatic vein thrombosis, occlusive on the left, and no radiographic evidence of why this might have occurred in terms of obstruction or masses. And she started on low molecular weight heparin and transitioned to warfarin. So with that, I'd like to pass the presentation over to Dr. Oliver, who will take you through thrombosis in PNH, as well as a few other sections. Monika.
Perfect. So thanks, Chris. My name is Monika, or Dr. Oliver. I'm a hematologist in Edmonton at the University of Alberta, and I also have an interest in complement-mediated disorders, with a big portion of my practice being dedicated to PNH. I also have significant disclosures with regards to clinical trials and advisory boards related to drugs in the complement space. So I've been tasked with talking about thrombosis and PNH. And we'll start with our third polling question, which is, in what scenarios might you screen for PNH? Is it A, just when a patient has breakthrough thrombosis despite being on anticoagulation? B, thrombosis, which is in atypical or unusual sites? C, thrombosis perhaps in a young patient, which was unprovoked or without explanation? Or D, thrombosis accompanied by CBC abnormalities or with an elevated LDH? Perfect. So the answer is coming up there. So no one tested with breakthrough thrombosis despite anticoagulation. About half of patients consider it with atypical site thrombosis, about a third with unprovoked thrombosis in a young patient, and less than a quarter with thrombosis with elevated LDH or abnormal CBC. So the question lies is why is there such a close relationship between thrombosis and PNH? And really, we must understand that there's a very complex interplay between the coagulation and the complement cascades. And people much smarter than myself have really elegantly tried to explain this. And we could spend the entire evening just discussing the links and the connections between both of these cascades. But I'm a more simple-minded person. And so I'll try to distill this really complex pathophysiology down to some recurrent themes. So as Dr. Patriquin has already mentioned, complement-mediated hemolysis really drives thrombosis through a few different mechanisms. One, we have those potent inflammatory mediators being released, platelets become activated, and we also have ongoing endothelial injury. And then in addition, we have a few other insults, one being we have issues with our fibrinolytic system with regards to breakdown of clots that are formed. And also we have impaired bioavailability of nitric oxide, which, as we know, is a very potent vasodilator. This is a quote that we love as PNH treaters because I think it really drives home a lot of what we want to say about PNH and thrombosis, and that is that we can safely say that PNH is the most vicious acquired thrombophilic state known in medicine. So it sounds dramatic, but it is true. Thrombotic events, as we've already alluded to, occur in about 30 to 45% of patients with PNH, 10% occurring at the time of presentation. And we do see clots in typical places, things like DVTs and PEs, but we also see increased involvement of atypical sites, so namely visceral and CNS thromboses. And often these can precede or even be the impetus to a PNH diagnosis. It is the leading cause of mortality in patients who are untreated or perhaps undertreated, occurring in 40 to 70% of patients. And that first recognized thrombotic event can actually be fatal and increase the risk of death by about 5 to 10-fold. And then thrombosis can occur in multiple sites, and that actually happens in about 20% of patients. And as well, chronic subclinical thrombotic events can actually go unnoticed. So this is older data, but very illustrative. This is Anita Hill and colleagues who had a look at a group of 10 patients with PNH with a median age of only 32. Their duration of their PNH diagnosis had only been 2 years, and they did have significantly large neutrophil clone size, as well as evidence of ongoing severe intravascular hemolysis with significantly elevated LVH. And in these patients, they underwent cardiac MRIs as well as pulmonary imaging. And remarkably, 60% actually had evidence of subclinical pulmonary emboli, with 20% having evidence of myocardial scarring. And again, appreciating that the median age here of patients was 32. And so I think really impressive and really illustrative of us wanting to drive home early diagnosis, because in the time from presentation to diagnosis and initiation of treatment, we have this gap wide open, leaving patients vulnerable to really accumulate some of these end organ insults. So what does thrombosis look like in PNH? Well, this is a nice graphic depicting venous versus arterial clots. And so I'll draw your attention to the proportion specifically of the venous clots. So about a third of patients will have clots in the deep veins, things like DVT. Only 6.5% usually present with PE. And then you can see a significant proportion with visceral venous events. So hepatic and portal veins, 16.9%, mesenteric and splenic vein, 18.5%. And then in addition, a smaller proportion with cerebral or IJ clots or superficial vein. And then importantly, a not insignificant proportion will have arterial clots as well. So this is, a disease that does not discriminate with regards to location of clot. So when I think about organizing PNH in terms of where I want to kind of put it on the spectrum or the ranking scale for inherited hypercoagulable states, this graph is a good reference. So if we think about our commonly inherited hypercoagulable states that, hopefully we're not testing for routinely, but things like antithrombin, protein C, protein S deficiencies, or perhaps factor V Leiden or prothrombin mutation, you can see that PNH really blows it out of the water with regards to relative risk of thrombosis. So compared to the general population, the relative risk of VTE in patients with PNH is actually 62-fold greater. So I think very, very impressive. The other scary thing as PNH treaters is that anticoagulation alone is not enough to protect these patients. So in one study, 50% of patients had thrombotic episodes despite being on anticoagulation. And this goes for secondary prevention as well. So after a thrombotic event, anticoagulation alone is not necessarily sufficient to prevent a secondary clot. The other thing that's important to note is anticoagulation is really not changing those driving factors that I mentioned that really drive thrombosis, specifically the procoagulant alterations of the PNH cells. And it's also important to not be fooled or perhaps comforted by a mild degree of anemia. So for example, if you have a young patient, they may actually have a brisk reticulocyte response despite having a significant amount of hemolysis. And so they may have only a mild degree of anemia, but they're still wide open to developing thrombotic complications. So this graph really nicely illustrates the increased risk of thrombosis with higher degrees or rates of intravascular hemolysis denoted by LDH. So patients with LDH, specifically more than 1.5 times the upper limit of normal, their incidence of clot is significantly elevated in comparison to patients who have an LDH, which is much more mild or perhaps within the normal range. And importantly, as I mentioned, thrombosis is associated with increased mortality. And so looking at the graph here, the black line at the top, age and sex match controlled. In that gray line, those are patients with PNH, but who have not had thrombotic events. So that there's still a gap there, but it's much closer. And then that notched line, with a significant gap, those are PNH patients who do have had thrombotic events. And so again, prevention is so key here, trying to prevent that first episode of thrombosis, trying to diagnose patients with PNH so that we can close these gaps. So let's recap a little bit with our cases. Anna, as you were mentioned, or as you remember, was the 33-year-old who had intermittent severe abdominal pain, multiple presentations to the emergency department with, unrelenting symptoms, nausea and vomiting, and ultimately sent home with iron supplementation and laxatives. So now she's back in the ER, and this time she comes in with more severe abdominal pain, fever, hypotension, and tachycardia. And this ultimately prompts abdominal imaging, which reveals an occlusive portal vein thrombus with extension to the splenic vein, the superior mesenteric vein, and non-occlusive IVC thrombus. And just like her counterpart, the other case, there was no masses, obstructions, or any other anatomical explanation. So further laboratory investigations were pursued, and she was found to be quite anemic. So her hemoglobin was 71, but interestingly, her platelets were mildly elevated or mildly decreased, 122, white cells just up slightly at 14.5, and her blood film did not show any morphological features of hemolysis, but were rather consistent with iron deficiency alone. She had significant elevation in her liver enzymes as well as her bilirubin, and her LDH was markedly elevated at 785 with the upper limit of normal of 230. Haptoglobin was undetectable, INR and PTT relatively preserved with a mild increase in her fibrinogen. And appropriately, she was started on IV unfractionated heparin and also underwent catheter-directed thrombolysis. Chartrice, as you can recall, was the 35-year-old female actually diagnosed with Budd-Chiari syndrome, again, with no clear explanation on her imaging. And she was started on low molecular weight heparin and then subsequently bridged to warfarin. Her laboratory investigations were as follows. So interestingly, she did not have anemia. Her hemoglobin was preserved at 130. Her white blood cell count was 4.8 with a normal differential, and platelets were just mildly reduced at 123. Her blood film was entirely unremarkable. There was mild elevations in her liver enzyme. She had a normal bilirubin, but again, her LDH was found to be markedly elevated. Haptoglobin was undetectable and coagulation profile within normal. So I think this illustrates two young patients, both with intra-abdominal thromboses, but both presenting different with regards to their laboratory parameters. And so I think important to ask ourselves, would you have suspected PNH in these cases? And if so, what do we need to do to diagnose PNH? And so that will bring us to polling question number 4. What is the confirmatory test for PNH? Is it A, high sensitivity flow cytometry with FLAIR? B, flow cytometry on a bone marrow aspirate specimen? C, LDH over 1.5 times the upper limit of normal? D, the HAMS test? Or E, the sucrose lysis test? So ding ding, nearly 3/4 of you got the correct answer, which is high sensitivity flow cytometry with FLAIR, and this is done off of peripheral blood. So a bone marrow biopsy is actually not required to diagnose PNH, although it is often done as part of our workup, and I'll explain that. LDH, a very important marker, but not diagnostic, and the HAMS test is fairly historic at this point. It's not really done very commonly. So we're really, harping on making the diagnosis of PNH, and really that is a key objective of our webinar this evening, because the diagnosis for patients is tragically delayed. And for the majority of patients, 62%, that delay is more than 1 year. But for up to a quarter of patients, that's actually greater than 5 years. So 5 years of presenting really with nonspecific, fairly common symptoms potentially to healthcare professionals who don't pick up or suspect a diagnosis of PNH. So when we're making a diagnosis of PNH, we have to kind of figure out where in our heads are we going to place PNH with regards to our differentials. And I kind of place it in two different locations. One is when I'm considering or working up a patient for hemolytic conditions or anemia, and then also on the thrombosis side of things. So with hemolytic conditions, without going into too much detail, often we're kind of stuck between these three diagnoses: autoimmune hemolytic anemia, a thrombotic microangiopathy, and then PNH. And really, when you send your hemolytic markers, your LDH, your haptoglobin, bilirubin, reticulocyte count, they're all, for the most part, going to be fairly similar. And so how do we distinguish between these entities? Well, I think the RBC morphology can be helpful. With the diagnosis of TMA, we're really looking for schistocytes, With autoimmune hemolytic anemia, generally we're seeing more spherocytes or potentially agglutination. But with PNH, often we just see a normal peripheral blood smear. So we don't have necessarily, specific markers of the RBC morphology, which are going to help or point us in one direction. So that's one distinguishing feature. And the other is the Coombs test. So the Coombs test or the DAT test, it's going to be positive in autoimmune hemolytic anemia, tends to be negative in thrombotic microangiopathies, and it is negative in PNH as well. The other time I consider a diagnosis of PNH is in working up patients for thrombosis, of course. So this is actually just a screen grab taken from the Thrombosis Canada website under the clinical guide for thrombophilia testing. And PNH is listed right up there with myeloproliferative neoplasms, APS, and HIT for patients who are presenting with clot, generally younger age, less than 50, with CBC abnormalities. So this is another time I consider the diagnosis. And this slide, I think, really nicely illustrates some clinical manifestations, what we call the 6Ps, that's on the right-hand side, but then also some key features of thrombosis. We don't want to be testing for PNH in every single, obviously provoked DVT or PE. We're really talking about unexplained thrombosis, potentially despite anticoagulation, perhaps in a younger patient, or in unusual or atypical sites. Especially so if we see any evidence of hemolysis, and certainly if we see other concerning features. So cytopenias, for example, unexplained iron deficiency, and again, perhaps DAT-negative hemolytic anemia. So this is kind of a very basic general approach. First, when we're doing blood work, we want to do a CBC, and we want to consider screening patients for hemolysis. So our regular hemolytic markers, but also paying attention to the peripheral blood smear and the DAT, as I mentioned, which help maybe narrow our differential diagnosis if indeed the patient is found to have hemolysis. Urine studies can also be helpful. So you can see from the photo here, as patients hemolyze more, the urine can become dark or even red, and often is mistaken with hematuria. And so really what we're looking for in the urine studies are hemoglobinuria or hemosideриnuria, so products of, more end-stage breakdown of red cells. As I mentioned, a bone marrow biopsy is often done, but it is not needed to diagnose PNH, but rather is usually done to rule out concurrent bone marrow failure. But flow cytometry is really the gold standard for diagnosis. So I don't think I really need to explain in too much detail the procedure or technique of flow cytometry, but as a refresher, it is a laser-based technique which detects the expression of surface and intercellular, to a lesser degree, molecules to help us identify and characterize various cell populations. It is just an orderable blood test, or sometimes it's done kind of as on a special hematology rack. And we use a particular substance called FLAIR to detect the absence of CD55 and CD59. And as Chris mentioned, it's really those markers that help protect our red cells from hemolysis, complement-mediated hemolysis. So we're looking for the absence of these. And when you get your PNH flow report back, you'll see two different populations reported. The first are the red cells, and the second are the white cells. The red cells are further broken down into type 1, type 2, and type 3 RBCs. And this will tell us the expression of those GPI anchors. So type 1, they have normal GPI expression. Type 2, they have partial GPI expression. And type 3, they have no GPI expression. But really, when I get a PNH flow cytometry report, I really hone in on the white cell population. So the white cells are a bit more reliable for two reasons. One, they're not affected by red cell transfusion. And then second, the lifespan of the white cell is actually going to be preserved, whereas the red cells are being constantly hemolyzed. And so if they're being constantly hemolyzed, it's hard to really get, a sense of the PNH red cell population. So if that was all a little bit too much for you to process, we have created this, I think, very catchy, if I can say, mnemonic to help remember signs and symptoms. So the C stands for cytopenias, A, aplastic anemia, T, thrombosis, RBC, a Coombs or DAT negative hemolysis, and H hemoglobinuria. And if your patient has perhaps one or a constellation of these signs and symptoms, then certainly we recommend screening for PNH with flow cytometry. And again, early diagnosis is really, really paramount to optimizing our patients and their outcomes. So with that, we'll take a breather and go back to our cases. So what happened to Anna? So she was the patient who underwent catheter-directed thrombolysis for multiple abdominal thromboses. And unfortunately, this was complicated by intra-abdominal hemorrhage. Her anticoagulant was then held, but she did develop an abdominal compartment syndrome. And with her anticoagulant held, her thrombosis actually progressed. Hematology was involved and ultimately made the diagnosis of PNH. Her flow cytometry report looked like this. So she had a large PNH granulocyte clone of 58.1%. Chartreuse, our second case, she was started on warfarin for her Budd-Chiari and unfortunately experienced some progression on warfarin. Hepatology was involved, who astutely, thought about a thrombophilia and screened her for PNH, and her PNH flow cytometry looked like this. So she was also identified to have a large monocyte clone of 36.8%, and then smaller RBC clones. And so I hope so far we've demonstrated, PNH is rare, it's important, it is very thrombophilic, and it needs attention. But how do we treat PNH? So when I talk about the management of PNH, I really break it down into 4 pillars. The first is supportive care. So patients are coming to us often anemic, and they may require some transfusion support with packed red blood cells. We try our best to optimize their hematinics, give them the building blocks to make cells, and we do that with folate or iron. As you can recall, one of our patients was iron deficient, probably from ongoing blood cell breakdown. Analgesia may be required to help ease some of the abdominal pain, and sometimes that does involve us prescribing narcotic. And then thrombosis. So if a patient presents with thrombosis, they need to be started on therapeutic anticoagulation, and this can be done with low molecular weight heparin, warfarin, or potentially DOACs, although we do have slightly less evidence for the latter. As kind of expert opinion, if we have a patient diagnosed with PNH and there's a delay to starting complement inhibitors, which are definitive therapy, we may actually start them on primary prophylaxis with anticoagulation just because we're petrified that they may go on to have a thrombotic event. And then there is a cure for PNH, but it is an allogenic stem cell transplant, and that is almost never employed for classical PNH just because of increased morbidity and mortality. So it's more commonly reserved for patients who have a bone marrow failure predominant presentation because we can cure potentially 2 processes, for example, aplastic anemia and PNH with 1 transplant. But the mainstay of treatment is actually complement inhibition. So currently, today, most commonly in Canada, we prescribe a drug called eculizumab, although this is changing, and Dr. Patriquin will speak to that. But first-line therapy is with distal complement blockade that usually targets C5. And if you can recall from earlier in the presentation, that is really at the end of the complement pathway, and that prevents cleavage of C5 to C5b, which further prevents the formation of the MAC attack. And that really drives the pathogenesis of PNH. This is an IV treatment, eculizumab, which is given weekly for the first 4 weeks, and then every 2 weeks, starting at week 5, the maintenance period, and fortnightly for essentially as long as the patient is alive. So it's ongoing therapy for them. With all of the complement inhibitors we'll be speaking about this evening, there is a significantly increased risk of meningococcal meningitis, and all patients, it is mandatory that they're vaccinated for meningococcal organisms, namely strains ACW and Y and MenB. So we usually do this the day of their first dose of complement inhibitors. Giving the vaccines slightly before this can actually precipitate more hemolysis and kind of rev up our complement system. And so we do it the day of diagnosis, the first day of treatment. And then we usually buffer for 14 days with prophylactic antibiotics until their immune status has come up. Often we offer patients indefinite penicillin prophylaxis while they're on these therapies as well. So these are some of the results of the phase 3 trials, namely Triumph and Shepherd, which led to the eventual approval of eculizumab. And these demonstrate really remarkable reduced intravascular hemolysis. This is looking at measurable LDH in patients following initiation on eculizumab. And here this demonstrates an 88% serum LDH reduction within the first month of treatment. And this was sustained 87% for the 36-month follow-up period. Importantly, eculizumab improves survival. So on the left-hand side, a Kaplan-Meier curve of age and sex-matched controls in comparison with patients with PNH, and you can see there's a large gap there. And then on the right-hand panel, patients after being started on eculizumab, and you see those curves really beautifully come together. This is something I usually share with patients when they're coming into my office and I'm initiating anti-complement therapy with eculizumab. I think it sets really appropriate therapy expectations. So within the first week, it's actually really satisfying as a physician because I see the LDH start to just plummet and start to go down, and that's really satisfying. Between weeks 2 and weeks 3, patients start to notice. They started noticing an improvement in their quality of life, and then between months 2 and 6, we start to see stabilization of the hemoglobin level and reduction in their transfusion needs. And then after the 6-month mark, those are really the long-term, benefits that we're seeing: ongoing improvement in quality of life, the protection from thrombosis, and then importantly, improved survival. So before I hand it over, let's just wrap up our cases. So Anna, as you can recall, our 33-year-old, she had a very challenging course with that catheter-directed thrombolysis complicated by intra-abdominal hemorrhage. She had VTE progression when her anticoagulation was held. She was urgently started on eculizumab, but unfortunately, despite this, developed multi-organ failure and a large subdural hematoma with midline shift, and ultimately was declared brain dead within 4 weeks from her admission. So a really, really, poor outcome for this patient. And of course, we begged the question, maybe on one of those previous ED admissions, had she been diagnosed, would her outcome have been changed? Chartreuse, on the other hand, she was our 35-year-old with Budd-Chiari syndrome. Hepatology ultimately made the diagnosis. Eculizumab was promptly initiated. She did develop a small subdural hematoma as well on warfarin, and that required an interruption in her anticoagulation for about a week. But subsequently, she was able to be transitioned to apixaban, 5 milligrams PO BID, and then has done really well, and her dose was actually reduced to 2.5 BID for ongoing maintenance. And with that, I'll pass it back to Dr. Patriquin to talk about novel therapies and to close out our program this evening.
Great, thank you so much. So certainly you've heard what can be done with eculizumab, and we've now had essentially 15 years almost of eculizumab experience in Canada, and over 20 years since the initial patients enrolled in the clinical trials in the UK, and obviously with improvement in survival, improvement in reduced thrombosis risk, improved quality of life, we've certainly achieved a lot. But novel therapies we do think are needed, and several are in either late stage development in clinical trials, or some are actually approved and working their way through regulatory processes in the country. And why do we need new therapies? Dr. Oliver, I'd like to break it down into these 3 C's of complications, convenience, and competition. In terms of complications, incomplete complement blockade you may hear about. This is fairly uncommonly a major issue. In that situation, it would be important to assess for the appropriateness of the dose and the frequency thereof. However, there may be patients, although I'm not aware of any yet in Canada, who may have no response to eculizumab or its relative ravulizumab, and that's because there is a C5 polymorphism that has been identified in about 3% of Japanese patients, as well as around 1% in Han Chinese descent, where the binding site for C5 is abnormal or different, such that eculizumab cannot bind to it. So novel C5 inhibitors in development or in late stage approval have essentially mitigated this by selecting a separate binding site. If you do have an effective C5 inhibitor, there is something iatrogenically that we cause as a complication in some patients, and this is C3-mediated extravascular hemolysis. And essentially what happens is, because we are so successful in blocking intravascular hemolysis, These atypical red cells are able to circulate, and they have more and more proximal complement bound to the outside. So more and more C3 can bind, and its split products are recognized by the reticuloendothelial system, primarily in the liver, but also the spleen and lymphatics. And this can lead to extravascular hemolysis, which in some patients leads to persistent anemia or even transfusion dependence. And I'll touch on a therapeutic that is directly, essentially, directed to improve that issue. Infection risk mitigation is something that we'll have to watch for, particularly as we start to explore novel therapeutic targets, and particularly dual therapeutic blockage, which is in the late stage development as well. In terms of convenience, as you've heard, eculizumab is given fortnightly, essentially long-term, as long as the patient has evidence of hemolytic PNH. And so novel therapies that are given IV are given much less frequently now, as I'll show you, every 8 weeks as opposed to every 2. But there are also new routes of administration that can really empower the patients to administer their own therapies, including subcutaneous infusions and injections, as well as oral therapies. And this obviously can significantly improve their quality of life, let them travel, let them go to school, travel abroad, go back to work. All of that is achievable with this, with a major focus on improving or reducing treatment burden while maintaining the efficacy and safety. And lastly, competition, more so in terms of the broader economics. These are all very expensive novel therapies, and we would anticipate that more than one in the same space with the same indication may drive down those costs over time. And what we've seen already is that the competition within the same space with other companies competing for the same patient populations, this has motivated more rigorous trial methodology, which I think is for the better across the board. And this paper from Kulasekararaj and Lozana earlier this year just shows you all of the different potential therapies that are in later development. There are others not even shown here, but obviously at the bottom right, you can see there's still a lot of interest in C5 inhibition. Of course, there's eculizumab, ravulizumab, which I'll touch on, but also there's crovalimab and the combo of pozelimab and cemdisiran, which are monthly subcutaneous C5 inhibition platforms. And there are also some eculizumab biosimilars that are available in some countries and in late stage negotiations in others. C3 inhibition with pegcetacoplan, I will also mention. This is a subcutaneous self-administered infusion given twice weekly, with the main indication being persistent anemia despite at least about 6 months of C5 inhibition. What I won't address, but happy to discuss during questions, are the factor D and factor B inhibitors, which directly address the alternative pathway of complement. These are small molecule oral inhibitors that are being tested, and late stage data were presented at ASH just this past year. So the two that are very close to being in the clinic, so you may be seeing these on patient Mars, are ravulizumab and pegcetacoplan. So ravulizumab, as I mentioned, this is a modified eculizumab. They essentially tweaked 4 amino acids for eculizumab, and this led to an ability to recirculate, and it's led to a 4-fold increased half-life. So patients can get this at maintenance phase every 8 weeks as opposed to every 2. And it works essentially by employing more readily the neonatal FC receptor, so it can recirculate better, and it can offload the C5 into the endosome while recirculating itself, as opposed to eculizumab also being degraded within the endosome. So quite fascinating engineering there, and other C5 inhibitors have used very similar technology as well. And there were 2 clinical trials, phase 3 studies published in 2019, comparing eculizumab and ravulizumab. The top study, 301, this was the naive study, and the 302 study were for patients who were on eculizumab, who were on standard dose. And you can see they were randomized to either continuation of this or the much less frequently dosed ravulizumab. And these were non-inferiority designs. And what was seen in the naive study was a essentially favoring of ravulizumab, met across the board the non-inferiority, including transfusion avoidance, LDH normalization, and key secondary endpoints, including a FACIT fatigue, which is a typical quality of life measure that we use in these studies, breakthrough hemolysis, which is essentially a return of uncontrolled intravascular hemolysis with symptoms once a patient has had control with that LDH below that 1.5 times the upper limit of normal cutoff, and hemoglobin stabilization as well. And very similar findings were seen with the switch study with change in LDH as the primary endpoint. But again, those key secondary endpoints favoring ravulizumab in terms of BTH, FACIT fatigue, and transfusion avoidance. And it's really important to point out in terms of breakthrough hemolysis, there are two different types that we talk about, pharmacokinetic and pharmacodynamic breakthrough. The latter, pharmacodynamic, can really happen at any point, probably in the context of complement amplifying conditions. With pharmacokinetic breakthrough in the ravulizumab arms, there were no cases of this, and no patients actually crossed that excursion line of 0.5 micrograms per mil of free C5. So it does suggest much better controlled terminal complement activation. And it won't surprise you perhaps that ravulizumab has been preferred over eculizumab in the data that were sent post hoc after these studies. Over 90% prefer ravulizumab to eculizumab. Almost 90% state that because of their just improved overall quality of life. Almost 100%, 98, said they prefer it because they're able to plan activities. And again, this every 8-week dosing allows you to do much more. You're not tied to a clinic room or having a nurse come to your house to give an infusion the same way. And almost 2/3 of patients also noted improvement in their control of fatigue. Now, there is a lot that we can do with C5 inhibition, but as I mentioned, there is an iatrogenic risk of extravascular hemolysis. And the Pegasus trial published in 2021 was the pegcetacoplan phase 3 study for patients already on eculizumab. And if I direct your attention to the right, you can see this figure. There was a 4-week run-in phase where patients continued to take their baseline eculizumab dose, but also started this twice-weekly subcutaneous infusion. And we're looking here at mean change in hemoglobin in grams per deciliter. And you can see really a mirroring of the two groups. And then at the end of 4 weeks, when they were randomized, they either went back to their eculizumab monotherapy with a drop back down to really their baseline, or in fact a bit below, or they stayed on pegcetacoplan. And the numerical differences to the left just show you the significant difference that was seen. So between the two groups, there was over 38 grams per liter difference at the end of the 16-week primary analysis period. And this really held out into the extension as well. But an increase from baseline of almost 24 for the PEG group, and actually a bit of a drop in those patients who were on eculizumab. The key secondary outcomes of Pegasus were analyzed using non-inferiority hierarchical analysis, and non-inferiority was met for transfusion avoidance. As you can see here, over 80% of patients were transfusion avoidant in the pegcetacoplan arm. This was also seen for change from baseline in reticulocyte count, suggesting that the marrow is having to work less hard as there is less hemolysis at play. Non-inferiority was not met for the change from baseline in LDH, and for that reason, the next analysis of FACIT fatigue was not tested formally statistically in the primary paper, although you can see really a clear difference in terms of FACIT fatigue here, and a recent post hoc analysis that we did showed really across the board in terms of the different domains that patients preferred pegcetacoplan over eculizumab in those situations. And just to circle back to the thrombosis component, Dr. Oliver already touched on this, so I won't spend too much time other than to say there are 3 scenarios of thrombosis that we really focus on in PNH medicine. The first, of course, is trying to prevent it. And in that situation, anybody who would qualify for a complement inhibitor, we would start them. First-line therapy in Canada is going to remain for now eculizumab or ravulizumab, with pegcetacoplan, as I mentioned, being indicated in situations of persistent anemia despite that. There are some patients who may not meet criteria, as you heard, and in those situations, if we thought that there was a higher risk of thrombosis, elevated LDH, high disease activity risk, we would have an important conversation with them about starting primary thromboprophylaxis, which we could ultimately stop once they start on a a complement inhibitor, assuming that LDH comes under control. In situations where patients have a history of thrombosis before starting a complement inhibitor, we still, in general, are continuing anticoagulation even after we start them on, say, eculizumab or ravulizumab. Although this may change over time, there is some data coming out of Hopkins that suggests in patients specifically on a C5 inhibitor, it may be safe to stop their anticoagulation with the assumption that you have formally addressed the provoking factor, namely their PNH. What we don't want to see is the last scenario, of course, and that's new thrombosis while a patient is on a complement inhibitor. And in that situation, as you would do in any other scenario, we would search for a provoking factor. Did they miss a dose of their therapy? Even if they didn't, are there complement amplifying conditions that we need to address, such as pregnancy, recent infection or vaccination or surgery? All of these would need to be looked for. And in most situations, we would start urgent anticoagulation. And if there was any suggestion of life or organ-threatening thrombosis, we would give an extra dose of eculizumab at this point. So to summarize what we've gone over, and this has been a long talk, so thank you for staying with us. PNH is a rare hemolytic anemia, but as you've seen, it can present with very common and nonspecific signs and symptoms. So it's really crucial to maintain that high index of suspicion, reflect on those catch criteria, and have a low threshold for testing. As you heard, it's a very simple test. It's peripheral blood flow cytometry, quite inexpensive. And if you do identify a patient, you can drastically change their outcomes with targeted therapy. It's that uncontrolled terminal complement, that natural history that drives many of the manifestations we can see up front, intravascular hemolysis, of course, but also the life-threatening thrombosis and kidney failure. And we can turn this around significantly with terminal complement inhibition, although we can at times unmask extravascular hemolysis, as I've just mentioned. And thrombosis remains that primary cause of death in these patients if they are untreated or undertreated. And as you heard from Dr. Oliver, anticoagulation alone is simply not enough. You need to block terminal complement regardless of the therapeutic of choice. And lastly, because of all of these novel therapies that are coming out, we are planning to systematically and internationally follow this and compare over time in a new tool. Just to really quickly introduce you to this, this is the International PNH Interest Group, PNH Registry. This will be essentially graduating from the current registry, which is owned by Alexion. This will be a multi-industry sponsored registry, but overseen by academics within the IPIG board. And this, as you can see, allows for silos for every company. So there are exclusive data within each silo, but common variables measured across all patients, which will allow us to track things over time as they move from one therapy to the next, even go on to 2 therapies at once. It'll allow us to look at the rates and risk factors for things like thrombosis, and also monitor outcomes for more vulnerable populations like pregnant patients. So hopefully this is a tool that will be active very soon. And if you are at a PNH center, you should certainly talk to your hematologist who may be taking this on. If not, we would always be happy to see patients to enroll. So lastly, I'll come to polling question number 5, which you may recognize. How comfortable are you in managing PNH patients? A, depends on the patient. B, prefer to refer. Or C, comfortable to manage. Okay, so we made a bit of a change. So I think we went from 3% to 9% who are comfortable managing. It depends on the patient still, absolutely. And prefer to refer, absolutely. You're welcome to do that. The Canadian PNH network is really across the country. And so anytime you have a patient, we would be happy to see them and either take them on or employ a shared care model. So with that, I think we can move to questions and comments. And thank you again for the opportunity to meet with you tonight. And we're hoping to have a great chat.
Dr. Patriquin, can you see that? I can read out the first question, and then maybe we can take them.
Sure.
So the first one was, as an internist, I often see unprovoked DVT or PE. How do I determine which of these should be screened for PNH? And this came from a David Kennedy.
Okay. Very important question. And I think if I look at the timestamp, it might have been asked perfectly right before Dr. Oliver presented some of those criteria. So in unprovoked thrombosis, we would look for things that may show hemolysis. So isn't there an elevated LDH? Are there cytopenias? Do they have marrow failure or some other contribution there? But even beyond that, it's not always very, very brisk hemolysis that's directly associated with thrombosis. So have they broken through anticoagulation and you can't otherwise explain why? Are they younger? And typically that's been used, the cutoff of 50, or is it an atypical site or multi-site? As Dr. Oliver mentioned, about 20% of patients will have more than one thrombotic site at the time of diagnosis. So if any of those were found, I would say it's certainly worth testing. Again, a fairly simple test to do and can have a drastic change in outcome if you find a positive.
Yeah, I totally agree. I think that approach is great. I think we often see physicians doing a CBC, for example, but I think, and perhaps they'll do an INR and PTT thinking about perhaps, antiphospholipid antibody syndrome. But often an LDH and hemolytic markers are not sent. Often patients are sick or they may have, just subtle changes in the CBC. So certainly I think an LDH is a starting place, but the other hemolytic markers, and if any of those are elevated, then certainly, I think that meets those catch criteria, and certainly PNH flow cytometry is totally warranted. And then for the second question, for younger patients with unprovoked cerebral venous thrombosis, should we be testing everybody for PNH? If so, is there a particular age cutoff to consider? So I agree. That's a tough one as well. But that would be, a younger patient, less than 50, atypical site, especially if there's no other provoking risk factors. Again, I would still order hemolytic markers, a CBC, but I would have a lower threshold probably in that particular scenario because it is such a high risk area of thrombosis, especially if a patient is, younger, let's say in their 20s or 30s, which is right around the time of diagnosis for most patients with PNH. I'd have a lower threshold to screen those patients as well.
Yeah, I completely agree. It could, again, really change your management if you were to find this. And we know, at least in some older series, they're small, but about a third of patients with PNH who were diagnosed in the context of cerebral thromboses died. So I think it's really crucial to look for this. Anytime there is a organ-threatening thrombosis, I would have a very low threshold for testing. It may be negative, and most of the time it may be negative, but if it's positive, then again, you have something that you can treat this patient with great success.
I agree. Then we have, why do patients with PNH develop iron deficiency?
Essentially, they can develop iron deficiency, all the reasons that we can develop iron deficiency, but in addition to that, the chronic low grade hemolysis can do this over time. So loss of iron in the kidney and excreted that way is a very common finding, and over time, this can also even have a direct impact on the kidney outcome. So hemosiderin deposition and things like that can be a kind of a secondary outcome for this renal loss of iron. So that's a major issue there, and even in patients who have control with C5 inhibition, the chronic extravascular hemolysis can still be a component there, and you can see really less or let's say a greater response to iron supplementation when that's also controlled.
Yeah, I totally agree. And as a young patient, as a young, female patient, I'm still gonna say that I'm still young. But just advocating for the Annas out there, that first case, which were, presenting with iron deficiency, and maybe she had normal menses, and she's just sort of chalked up to saying this is menorrhagia, this is iron deficiency. But certainly, if they're on treatment, it's not improving. We have to look for other causes, PNH being one of them. We're getting popular, Chris. Look at this. There's more in there. All right. Is there an explanation as to how/why some bone marrow failure patients can have very large PNH clones without developing any evidence of hemolysis or overt PNH disease?
So yes, and we're working on it. So what has been shown in more advanced genetic studies is that some patients may have more than one mutation. So that PIG-A mutation may happen many times, and there's insertions, deletions that can all occur on the X chromosome. And if you have more than one clone, you can sometimes have variable expression in the red cell and white cell lineages. But it's an area that we certainly see, and for that reason, it's an area or it's a type of patient that really needs close follow-up because they may not have hemolysis right away, but this is a patient who would be at high risk of developing this over time. So following those along and seeing whether or not they would meet criteria for treatment eventually is really crucial there.
Yeah, I totally agree. And that leads into the next question. What about the opposite scenario? What do we do with patients with small clones, frequency of follow-up, and if the clone disappears, can you ever safely discharge them from your clinic? So the last slide we were mentioning the IPEG registry. And so the IPEG registry, and Chris, you'll know better, but we're really not discriminating for patients with classical PNH. It's patients even with small PNH clones. And I think this is a great area of research. So certainly if the IPEG registry clinical trial is coming to a site near you, certainly keep these patients in a little reservoir to eventually bring to whoever takes on the registry in your area. But to answer the question, usually really small clones, like less than 1%, they're very often or almost always not clinically significant. So really the threshold tends to be more than greater than 10%. If it's less than 1% and has been stable for some time, I usually monitor annually. For example, let's say a patient with aplastic anemia who I'm seeing in my clinic. If the clone size has been changing over time at all, we'll usually monitor more frequently, more on the area of every 3 to 6 months. And I think, if you have a family doctor, and I think we want to empower family doctors to know that they can order PNH flow cytometry too. So if you've been following the patient for a few years, the PNH clone size is less than, let's say, 1%, or less than 10% even, no other clinical manifestations of PNH, and normal CBC otherwise, I think it is probably reasonable, if you have no other reason to follow them, to eventually discharge them to the family doctor to monitor perhaps annually.
Yeah, absolutely. I agree. And the last part about if the clone disappears, can you discharge them? As long as you do have good follow-up, that's a possibility. What I will say about the disappearance of a clone, it is a very uncommon scenario. We think less than 5%. The important piece there is if you are seeing this, particularly if they're dropping below that 10% cutoff, number one, they may lose the potential to be covered if they are on a complement inhibitor. But number two, that could reflect clonal evolution. So anytime, as Dr. Oliver mentioned, you don't have to do a marrow to diagnose PNH, but I would always do a marrow when someone's if their clone is changing and dwindling, because that may suggest that they're evolving into something else. So I would rule that out, and then if everything looks great, then I think eventually they could be followed by primary care with you at the other end of the phone if there's ever a question.
All right. Do all PNH patients who develop aplastic anemia need bone marrow failure, or need bone marrow transplant rather, or can some be managed by complement inhibition? If yes, what percent of bone marrow failure PNH ends up needing a bone marrow transplant?
In general, the indications for transplant, PNH is kind of a traveler along with the marrow failure component. So if there is another indication of progressive aplastic anemia or MDS where you would consider a transplant, certainly you can do that. Most of the time, as Dr. Oliver mentioned, these patients may have smaller clones, but there are some who have concomitant hemolytic PNH on a complement inhibitor. And in that situation, we would continue the complement inhibitor until the transplant, particularly around induction, and ATG can be very thrombotic and hemolytic. So I would always kind of bridge them in that situation if that was the type of scenario that you were looking to. But it's really only this marrow failure component that we would transplant or even consider transplant. In the past, patients with refractory thrombosis have been transplanted as well, and the outcomes, in fact, were worse, and that was based on a large series from the French group. So they actually do better with just supportive care than actually transplanting them. What percent get end up needing a BMT? Very few in Canada, again, but it's really, again, the marrow failure decision that would drive that. So if they are otherwise eligible for a transplant for aplastic anemia, then they would get it. If not, then you can give them immune suppression as you would otherwise. And there are data both from the international registry and from some larger groups in the UK showing that concomitant use of complement inhibition plus immune suppression does not undermine either of those. So you can do both at the same time without worry.
Yeah, and I have a number of patients because I do follow a number of aplastic and even MDS patients, and I manage them just as I would, but then I'm keeping a close eye on their PNH. And I have a few who are on anti-complement therapy, either with eculizumab. I have a patient who's on ravulizumab, for example, and they're still on maintenance, cyclosporin and even eltrombopag. And I just really closely monitor for thrombosis and kind of monitor and manage both symptoms in tandem, or both diseases in tandem. And then a very small proportion, as Chris said, will end up, going on to actually need a transplant. And I think the last one I see in the chat there is, are all flow cytometry done with FLAIR? And is FLAIR cytometry effective for ruling out PNH? Is there ever cases of PNH with negative flow?
So there are case reports, but I have never seen one. In terms of the flow cytometry, the guidance really comes from the International Cytometry Society, so the ICCS. And FLAIR is helpful because what it does is it binds directly to the GPI anchor. So it's a very efficient method for looking for the expression on the surface. FLAIR is typically, in most centers across the country that I'm aware of, combined with CD157, and you can essentially do a very efficient 1-tube 5-color flow to diagnose PNH, because you can identify the white cells and you can identify the absence of the GPI anchors. There are other kind of concoctions of isochromes that you may use, but FLAIR is definitely the most common, and it's the most recommended in terms of gold standard by the ICCS and other bodies.
Yeah, I don't think I have too much to add, but just making sure it's PNH for flow cytometry. So if you're not familiar, I mean, we're hematologists, so we order FLAIR cytometry for other reasons. But if you're less familiar, you want to make sure you're ordering PNH specific for, or sorry, flow cytometry specific for PNH, and not, for example, a myeloid panel, which is going to have different markers looking for a totally different disease. Perfect. I think that is all that is in the chat. If there's no other questions, then I think we're getting close to quitting time here.
So on behalf of Thrombosis Canada and our participants tonight, thank you, Dr. Oliver and Dr. Patriquin, for this terrific presentation tonight. Have a good night.
Perfect. Thank you so much again for the invitation. Good night, everyone.
Good night.